So without further delay, I will introduce Nick, who will start our session today, and we'll be talking about Richter's transformation, diagnosis, treatment, and dilemma. Nick is a colleague of mine who is a consultant hematologist in Nottingham University Hospitals. He's got specialist interest in CLL. Nick completed his PhD studies in Navarra in field of DNA methylation. Over to you, Nick. Thank you for taking your time to prepare and tell us all about Richter's.
Right. So yeah, again, welcome. So we're going to go through a few things, and the way I structured the talk was basically to go through some of the questions that one would want to know about Richter's, and what not only on the setting of the MDT, but also on what would you discuss with your patient when you have a Richter's patient in front of you. So when do you suspect it? When is PET-CT useful? It's an important question. Is Richter's associated with prior treatment of CLL at all? What have we learned in the last few years from the Richter's biology, and how has it been translated into practice or not? Where are we still using our CHOP for this so many years down the line? And what to offer to people who is not fit for our CHOP, which is unfortunately not a minority of these patients. And then finally, a few slides on Hodgkin Richter, which is far less common and perhaps less literature available about it. So when do you suspect the Richter's? Is no, I think this is not a big surprise. What I'm going to tell you about this is when any physical deterioration, any rapid growth or discordant growth of lymphadenopathy. The lymph nodes of CLL and any other sort of chronic lymphoid malignancy tend to grow harmonically, or sort of at the same pace. And when there's one that grows disproportionately, then that's where the alarm bells should be ringing. Fever in the absence of infections, quite frequently. The Richter's is associated with EBV, and hence that could cause in itself sort of inflammatory type of disease with fevers, etc. Marked and sudden rise of the LDH, indicating rapid disease kinetics, and essentially those are the main ones. And so what do you do? Well, you initially do a PET scan to look for a biopsy site, and do some image-guided biopsy, a bone marrow biopsy, which is always useful. And we were debating about this yesterday, whether we do bone marrow in CLL or not. But I think it's helpful to know the degree of bone marrow infiltration at the time of diagnosis, irrespective of the full blood count. And I think that is important because it will determine how you manage your chemotherapy, your dose reductions, etc. So I think in the specific case of Richter's, I think a bone marrow is very useful. And an echocardiogram, obviously, because you need to assess anticycline fitness. So that is my first question answered, I hope. But then the next question is really PET useful? So this is a study that was published some years ago, with 92 patients with CLL, of which a quarter of them roughly had Richter's transformation. We're looking at whether or not we could find some use in the PET. So I think the PET has a dual use here. First of all, is to assess potential sites for biopsy, and I think it's always good practice when you're considering or suspecting high-grade lymphoma of any sort to do a PET scan, because it will help you to find adequate biopsy sites. Sometimes ones that are not readily evident on physical examination, or perhaps not readily evident on a CT scan. And the FDG avidity, and the next question really is whether or not the FDG avidity of the PET scan can give us any meaningful information. And this study, as you can see, the Richter's, the median SUV value for the Richter's was 11, whereas it was like nearly half, 6.4 for the CLL in progression. And they managed to establish that SUV of 9 or above carried a 72% sensitivity and specificity for diagnosis of Richter's. But more importantly, sorry, if you have an SUV less than 5, is very, very unlikely. It's very, very specific for CLL, and you can almost always exclude Richter's if that's the case. So it is helpful to suspect, and it's also helpful to direct your biopsy, because if you have multiple lymphadenopathy, you want to target that one that is most avid on the PET. Otherwise, you might just get CLL and be content thinking that the patient has just got progressive CLL, whereas and missing Richter's transformation. So to quickly answer that second point, the PET-CT is a very useful tool, as it has demonstrated in other aggressive lymphomas, and I think all Richter's patients should be having this at baseline and also for follow-up. And you can see from this paper the SUV max for all the Richter's patients compared to the CLL in the blue dots on the Richter's and the red dots. So you can see the median. It tends to be higher. There's some overlap, obviously, so there's not an absolute discriminatory test, but is very helpful. So what are the characteristics of the Richter's transformation? It's a relatively rare, but more frequent than we would want to. Really, it has a 5 to 10% incidence in CLL patients. It's very, very linked to unmutated IGHV CLL, although it's not an absolute, and that goes along with other sort of genetic abnormalities that are more frequently associated with IGHV unmutated CLL. There is this new concept, or relatively novel concept, which is not that novel. It's been published for the first time nearly 10 years ago, about the clonal relationship between the CLL and the Richter's transformation, and about 80% of the DLBCL Richters are clonally related to the parent CLL, and that has some importance. It has, as I mentioned, quite significant enrichment of disease mutation that are associated with aggressive biology, rapid diseases, rapid cell turnover, and aggressive behavior such as MYC-P53, and more importantly, Notch1, which we'll touch upon in a few slides, because it is emerging as a very specific marker for Richter's disease, Richter's transformation. 90% of the Richters is DLBCL, and the other 5 to 10% is Hodgkin Richters, which we'll also review at the end. And this is an interesting image touching upon this issue of the mutations. As you can see, the proportion of mutations of these genes clearly just increases quite significantly when you think about treatment-naive relapsed refractory CLL and Richter's transformation, which just speaks volumes about how the clonal selection works in this disease, intersecting the more aggressive and the more sort of aberrant clones in terms of genetics. And yeah, about 2/3 is clonally related, 70 to 80%, as I said. That's for DLBCL. For Richter's, for Hodgkin Richter's, it's more debatable because there's less work done on this, but it's probably about a third or 40% of these are clonally related, and for Hodgkin Richter's, this is clearly less relevant or less important as it is for DLBCL. So on to my next question. So what can we tell the patients when you have a Richter's and the patient has had several lines of therapy for CLL? Has the treatment had an effect in this? Has this been caused by the treatment I've had? And it's a really important question, and it has several nuances to it. So if you look at the treatment-naive CLL, long-term studies that have looked at Richter's transformation, the risk is 0.5% per year. So there is an inherent risk of transformation that comes based on the biology of disease. This is the CLL is an anti-apoptotic disease, but in some instances it is proliferative, particularly the unmutated, and that's why the risk goes with the unmutated. They're more proliferative, and any disease that's actively proliferating is therefore accumulating risk of acquiring further mutations and therefore transforming to Richter. So there's no surprise that there is an ongoing risk for even treatment-naive patients. But if you look at patients after chemoimmunotherapy, that risk is nearly doubled, 1% per year of risk of Richter's transformation. So you actually double the risk of Richter's after giving patient a chemoimmunotherapy. But obviously, we've spent the whole morning yesterday talking about why we're not giving chemoimmunotherapy anymore. So this is a relatively still present risk for most of our patients because many of our patients have received chemoimmunotherapy, but that's going to disappear over time. So the next question is then, what happens to novel agent? And I'll touch that in a moment. So they've established several risk factors for Richter's apart from the previous treatment, and there are several studies. One, as you can see, the first one is from Davide Rossi from Switzerland, and the other one, another sort of multinational retrospective study of nearly 4,000 patients, and they've established all these associations and risk factors for Richter's transformation. As you can see, the use of FCR has a increased probability of Richter's of nearly 3 times. The unmutated nearly 4 times compared to the mutated. The stereotypy of the IGHV receptor, there's a specific subtype that clearly confers a really high risk of Richter's. This is very difficult to measure in the routine practice, and for the moment remains investigational, but is really, really relevant. I think genetic mutations and the fourth one are 3 times risk, and the Notch mutations nearly 4 times increase in risk. So these are the things you should be looking at on a patient when you diagnose, and then if you want to counsel that patient regarding the risk of Richter's, you should. But then we'll touch upon that. That's not very easy to do when you're diagnosing a CLL, because you're trying to, and there's something we might discuss in the debate later, because you're trying to sell to the patient the concept of a indolent, slow-growing disease. Don't worry about this. It's not going to affect your life quality. And then if you throw in the risk of Richter's, then in my experience, people just gets a bit baffled and what you've been telling me this for 10 minutes, and now you tell me that you can have a transformation and suddenly have a risk of death, and that's very significant. So I think something to discuss. I in my practice tend to discuss this maybe in the second or third visit where people has digested the CLL diagnosis a bit more. Otherwise, you kind of sound a bit contradictory on your speech. And this is the incidence curve of Richter's from another really big series of nearly 1,600 patients. As you can see, the incidence of Richter's from diagnosis and from treatment is very different, meaning, in other words, that the treatment does have an impact on the incidence of CLL compared to the treatment-naive CLL. And another big series published in 2019 with nearly 7,000 patients, demonstrating that about a third of the cases appear in untreated CLL. So there is still a risk for people even if they haven't had any treatment. Right, so we continue on the prior therapy, as you can see, and two big series published on this one in 2020 from the Mayo Clinic, looking at significant number of patients over nearly 8 years of time. They managed to diagnose 200 Richters on a time span, which is quite a lot if you think about it, from a single center. Anyway, again, similar percentages, about a third of them never received CLL therapy before. And the number of therapies received further increases the risk of Richter. So the risk is much higher if you have received 2 or more lines of therapy compared to just one, as you can see in the graph a couple of Mayo curve below, where the red curve is the incidence of the survival of Richters after having more than 2 lines of therapy. In this big study, this has demonstrated that nearly a third of them are associated with EBV virus, as I told you before, and again, as we've discussed earlier, most of the Richters have, or a significant proportion of them have these high-risk genetic features such as double hit, triple hit, microarrangement, TP53. But again, all these studies I've shown you and all these associations I've shown you, they've all been based on chemoimmunotherapy. So what happens with novel agents again? So this is a study looking at ibrutinib, nearly 500 patients treated with ibrutinib in about a 10-year span, in which nearly half of the progressions that occurred during this period were Richters. And that equates to about 10%. And so in 10 years, that's about 1% per year. So you think, this is an important concept, because we think that the sort of genotoxic effect of chemotherapy is the one that's causing that increase of risk. But if you do treat with novel agents, that risk is increased anyway, and to a similar extent. So it's not actually that much of the importance of the sort of genotoxic and effect of chemo is not that important, as you can see, and that is replicated for all the novel agents. As you can see, this rather small study of venetoclax with nearly 120 patients had an incidence of Richters of 16%. You would think is a little bit higher, but these patients were heavily pretreated, and at the time that this study was done, that was the last ditch of therapy, and the median line of therapies for these was more than 3. So you can probably infer that that's what the cause. But these 2 studies I've shown you are from ibrutinib and venetoclax used in third and plus line of therapy, as were the initial studies that were done with these 2 drugs. So what happens in front line is perhaps more informative, and so if you look at the RESONATE data, 8-year follow-up of ibrutinib front line, they've had 2 cases of Richters. That's about 2% in this last one. So again, small risk, but seems to be slightly higher than for treatment naive. And for the CLL14, again, 1% of cases in about 5 years of follow-up that we've had, or 6 that we have now. So again, about 1%. So there is a slight increase, I think, in the risk of Richters, even with novel agents. And this is something we should probably still be talking to our patients about. So what's happened? What happens with Richters? How do you tell the patients what's gonna become of me, or what's gonna happen with me with this new diagnosis of Richters? And sadly, we've gone through 2 decades of research, and sadly we haven't had much progress. So you can see this previous series on the left-hand side from the MD Anderson back from 1996 shows that the median overall survival was 8 months, and this real-world cohort from the US, nearly 10 years later, the overall survival is not very different. You can see the median is different, but what's really important is that the tail of cure that you can see, the percentage of long-term remissions, which hasn't changed very much. And don't be misled by the sort of the apparent differences of the curves, because you can see this time scale is very different. So the right-hand side is only up to 3 years, and the other one is up to 16 years. But the overall survival or the rate of cure is very low, and we haven't gained very much in the last 10 years. So still a very significant unmet need, and a lot of work needs to be done in Richters. And the main hurdle we have to deal with patients with Richters is actually age, because you can see in this curve where you can see that the survival of the CLL, which is on the solid lines, so you can see whether or not they are above or below 70 years old, and the dotted line is the survival curve of the Richter's transformation, whether they are below or above 70 years old. On the bold line is the one that is less than 70, and the sort of the non-bold line is the one that are above 70, and that's about a third of the cases of Richter's that are above 70 years old, and that poses several difficulties in terms of delivery of chemotherapy, tolerance to side effects, etc. And their survival is, as you can see, very, very poor. And this is an interesting graph that compares the survival of the Richters with the CLL that you can see is still pretty dramatic. So what did we do then? We try to understand the biology a bit more, because I think that's the key to knowing what to do with the Richters, because chemotherapy has clearly not been an answer for many years. So I hope I'm not going to bore you too much with the detail of this genetic data that I'm going to show you. I'm going to try to be as lay as I can explaining the results. So this is the study that was conducted by Dan Hodgson on DLBCL, using the new or establishing these new genetic classification of DLBCL that you've probably been familiar with, have heard about. And this is a groundbreaking work that has been actually published by several groups, a French group, UK group, and American group at the same time, which basically has looked at thousands and thousands of patients with DLBCL, looking at the wide spectrum of genetic mutations and trying to classify them in groups. So in the table you can see on the top left, it's the easiest way to say is that every column that you can see is a DLBCL case, and every row is a different type of mutation. And what they do is then they cluster these. What they do is a technique that's called unsupervised clustering, which means that the computer system just bunches different diseases together in terms of how different their mutation is. As you can see, there's a group that they call MYD88 on the top right, and there's another one that's called BCL2, for example, on the middle. That's the 1, 2, 3, 4, the sixth group that has a significant proportion of BCL2 mutations. And you're going to ask yourselves, what am I telling you this? Well, for two reasons. Then this has been done by 3 groups at the same time, and they surprisingly found very similar results. And they have obviously named the subgroups slightly differently, and they've done the categorization slightly different, but overall it has been very consistent. And there's a small subgroup that you can see in red, highlighted that there with an arrow, which in the table up on the upper part is called N1, which is characterized by the Notch1 mutation, which is a small subtype of DLBCL, has a very poor prognosis, and we think might be enriched by Richter's transformation. So it might be that this is the signature of the Richter transformation. And as you can see, the 5-year overall survival that you can see on the graph that's on the right-hand side of the slide, you can see the bars with the green are the ones that are either the N1 or the Notch1 subgroup, and you can see the overall survival compared to the rest of the DLBCL cohorts is very poor, and that is consistent with what we see in Richter. So it looks like we might have found a subgroup that might resemble Richter's here. So and they've done quite deep genetic investigations on samples of Richter's transformation, trying to investigate whether or not how are they different to other DLBCL. And this is the study that goes back a bit more than 10 years ago from Davide Rossi, that for the first time established the clonal relationship. So essentially what they do is they look at the IGHV mutation on the Richter's disease clone, and they compare it to the germline mutation of the B cells, and basically whether or not they are alike or not. They call it, sorry, with the CLL, and they're related or not. It depends on how similar they are. Essentially meaning that the related have arisen from the CLL clone, and the unrelated, they have arisen sort of independently as any other DLBCL would have. You can see the survival curve on the right from the clonal related and unrelated, which makes a big difference. And you might immediately try to think that the clonally related, perhaps Richter's is the one that has been previously treated, and the one that's clonally unrelated perhaps is the one that has been untreated before. But that's not the case. This is a different biological feature, because you can see on the table on the left-hand side the untreated CLL represents about similar proportion of patients in both related and unrelated CLL. So it does seem to be something that is independent of prior therapy. And this is, the big study that for the first time showed that there was a high incidence of TP53 microarrangements, BCL2 amplifications, etc., and they are very different in between the related and unrelated, and that's why it explains the sort of poor prognosis in terms of a more biologically aggressive disease. And a few years later, the same group published a bigger cohort with nearly 600 CLL patients looking at the Richter's transformation, and they found and described the Notch1 mutation being very present in more than 40% of Richter's transformation cases. Most of them are those who are clonally related, and very rarely present in the ones that are clonally unrelated. So if you think about what I showed you in the slide before, that N1 group or the Notch1 group of DLBCL are probably those who are clonally related DLBCL mostly, and then those other are kind of intermingled with the other groups of DLBCL. And the risk of death for Notch mutated Richters is very high, like 5.8 in this subgroup, which is a lot bigger, and has specifically looked at this mutation. So it is a significant risk factor for poor prognosis in Richters. And lastly, about biology, I'm not going to bore you about anymore about biology, but this is an excellent paper that was published in Nature Medicine last year from the Barcelona group. And what they've done is they've done multi-omics and single cell analysis. They've done proteomic, transcriptomic, epigenetic analysis, and single cell analysis of several cases of CLL on sort of longitudinal follow-up, and some of them with Richter's transformation. And the single cell analysis is very interesting because they have been able to demonstrate that in a reasonable proportion of these patients, which are still a handful of patients only, because you cannot afford to do all these tests in a big cohort of patients, but in a reasonable proportion, were able to detect at a single cell level the Richter's clone early on the diagnosis of CLL and during the follow-up. And also there were some that are actually kind of the Richter's clone kind of emerged from nowhere. But it just comes to tell you that there may be some patients that have a predisposition to develop Richter's, and as you go and treat them, then you're selecting these clones as they're meant to be probably resistant to or tend to be more resistant to the treatments, and hence select themselves until they produce the overt Richter's syndrome. And basically, even though they were able to identify these cells early on in the development or the natural history of the CLL, these cells were characteristically and had the profile of epigenetics and of gene expression and everything that was found later on the sort of Richter's disease. So there weren't very many changes except for some additional mutations that they acquired. So and these sort of in-depth analysis of the transcriptome and the epigenetics, etc., has revealed many important insights. They have been able to come up with some new targets that we'll have to see if they are translatable into the clinic, but also they have realized that the Richter's has a significant BCR independency in the biology, and hence BTK inhibition in these diseases may not be the answer or the unique answer to treatment, and that is relevant for what I'm going to show you later. So we'll still have to have a proper link between whether or not the clonal relationship, related versus unrelated, has anything to do with N1 subtype, and how is that closely related, and whether or not the non-related Richter's fall into any other category of the DLBCL that will help us understand further the biology. And this is work that is in progress, but we still have to kind of get that link properly sorted. So enough biology, and apologies, I'm molecular biologist, passionate molecular biologist, so can't help it. But now we're going to go into a bit more clinical data. So the next question, why are we still using R-CHOP? And the treatment of is based on R-CHOP as it was a de novo DLBCL, and we haven't changed that. So this is the first paper that was published nearly 10 years ago. One of the papers that was published nearly 10 years ago, which showed a median PFS of 10 months and a overall response rate of nearly 70% with R-CHOP in patients with Richter's transformation, which is the blue curve that you can see on that Kaplan-Meier curve. And as you can see on the survival curves I've shown you before, we haven't made much difference in these many years, and we have tried, and there's several studies, and I've just showcased this one that was a UK-based study of trying to incorporate obinutuzumab to CHOP. There was evidence at the time, as we've seen yesterday in the course, that the obinutuzumab was definitely a better antibody for CLL, and hence the obvious logical train of thought was, well, if obinutuzumab is so better for CLL, then why don't we try in Richter's, because it might be better than rituximab? And unfortunately, it didn't make much difference. This was a single arm study of only 37 patients with Richter's, but the median PFS was again 6 months, and the response rate was 46%. So adding obinutuzumab didn't seem to make much difference to the outcome of Richter's. And there are many other examples. These are just a handful of them, where you can see the overall response rate column and the median PFS column, or the 1 year or 6 months or 2 year PFS, whichever you want to look at. However, each of them was reported. But essentially, the gist of these studies is that we haven't made progress, and even going into very aggressive regimens such as EPOCH or hyper-CVAT, they haven't made any difference. And obviously, there are two reasons for that. So if you think about more aggressive chemotherapy such as EPOCH and hyper-CVAT, that definitely immediately skews the type of patients you can offer this treatment into the younger and fitter, and therefore the older are still left out, and the outcomes continue to be quite poor. So and the response is typically short-lived. So the main message here is always consider clinical trials, and when you have a Richter's transformation, you should immediately be thinking about if you can send your patients to have a clinical trial. And it is worth mentioning here that you may all be aware of that we can use now polatuzumab R-CHP for treatment of Richter's transformation, which was kind of grouped in with the DLBCL in there, and is made available. But it is fair to say, and it is important to make the point here, that there's no evidence for the use of this in Richter's. There's no specific evidence of Richter's. It is a type of DLBCL, so you might argue it's not entirely wrong, but the fact is that we're spending a lot more in the regimen that's more expensive, and we still don't know if it's going to be more effective in Richter's, and we don't know if that small benefit in PFS that was seen for sort of DLBCL as a whole is going to be translated in Richter's, and time will tell. And one hope that this was going to be revised in a few years. So I'm not discouraging people to not use polatuzumab R-CHP, because I think it might do some good, but it's important to mention about polatuzumab R-CHP that patients do have a low high risk of febrile neutropenia with this combination, and they have a lot of high percentage of infusion-related reaction, delayed infusion reactions, etc. So it is not trivial, and if we're thinking about patients above the age of 65 or 70, we should be careful. And obviously, more importantly, the evidence of polatuzumab R-CHP is with full dose R-CHP, so there's no evidence about the use of polatuzumab with attenuated doses of R-CHP. So that's also something that we should be mindful of. And clinical studies have been advocating clinical studies. So this is the still active STELLAR study that I hope that most of you are familiar with, which is has a randomized arm and a single arm platform, which we're trying to investigate whether or not the addition of acalabrutinib to R-CHOP is of any benefit for patients with Richter's, and that's fundamental and study that I'm going to discuss with you in a few moments. So all of the calls are open. This trial has struggled to recruit around COVID and is being late on recruitment, and there's been several attempts to rejuvenate it. So please keep it in your top of mind and do refer your patients for this study that is potentially relevant for Richter's based on the early results of the acalabrutinib in single agent. There is a role for stem cell transplantation in Richter's. It looks like it has been. This is a work that has been led by Kate Swinerski from UCL a few years ago, doing a EBMT registry study, finding out how many patients have had some sort of stem cell transplant after having remission with Richter's chemotherapy, given the fact that the remission is very short. So there's only a relatively small groups, 34 that received autologous transplant and 25 that received allogeneic stem cell transplant. And bear in mind, these are patients that have reached a remission. So we don't know exactly what the allogeneic or autologous stem cell transplant adds on, but the overall survival of the autologous and allogeneic is not bad for Richter's, thinking about all the curves that I've shown you before. So this has led to at least recommendation to consider consolidation with transplanting patients with Richter's who have achieved a remission. This is the level of this evidence is not as strong. This is obviously a retrospective study from the EBMT, but this is something to consider in younger and fitter patients. You might want to consider, and I don't think you'll be criticized for doing this at all. There's another study from the MD Anderson that's also published in 2006 that's shown that only 15% of the Richters received any sort of consolidation. So this is something that might be useful, but this MD Anderson study just comes to tell you that it's reserved for a very small minority of patients. So we're still giving R-CHOP, which isn't great, but obviously we have a third or more patients we can actually even give anthracycline because they're frail or they're cardiac unfit. So what do we do? So this is obviously the published a study of Paul Fields in 2013 looking at RGCVP in DLBCL. As you can see, the outcome curves are not too dissimilar to the ones that we would expect for an elder population with DLBCL treated. My experience probably in the real world is that this combination is not as good as, but is a good option for treatment for DLBCL. And I would, extrapolating the results from DLBCL, I think that's very reasonable to use in people who are anthracycline fit or otherwise fit for a relatively intensive chemotherapy. So we have I've looked very hard, see if there was any data about GCVP and Richter's, and there isn't any. So this is evidence-free. So, but I also think there's not unreasonable to think about this regimen when you have an anthracycline unfit patient. What other things can we do? So we can do BCR signaling targeting, which has its caveats, as I've shown you before from what we learned from the biology of the disease. We can do T-cell engagement with either checkpoint inhibitors or bispecific antibodies, and lately CAR T-cell therapy. So BTK inhibitors. So ibrutinib was tried on early for Richter's, and the duration of response was very short, and the outcomes weren't very good. And obviously ibrutinib at the time was a big hit and a big success in CLL, so the company was never interested in pursuing ibrutinib in Richter's. So it was kind of left. And then acalabrutinib picked it up a few years later. There's one phase 1/2 study that has shown activity in 29 patients with Richter's with an overall response rate of 40% and a reasonably good duration of response. So this was the base of the use of acalabrutinib in combination with R-CHOP in our STELLAR study, and hoping that this efficacy is potentiated by the combination with R-CHOP. There's no mature data of zanubrutinib yet, but there's some data of non-covalent BTK inhibitors. Nemtabrutinib has led to overall response of 50% in a small cohort of 6 patients, has been presented in ASH in 2019, and the pirtobrutinib also good response, 6 out of 8 patients that was presented in EHA in 2021. I'm going to show you a bit more data about pirtobrutinib. This has been further updated in ASH 2022. Median lines of treatment for Richter's is 2, so it's heavily pretreated population of Richter's, and you can see the waterfall plot looking at many patients achieving a response, and with an overall response rate of nearly 50%, which is not bad at all. And the progression-free survival is about 20% at nearly 2 years of follow-up. So if you look at the curve of R-CHOP in R-CHOP fit patients, this is not very different, and bear in mind this is a heavily pretreated population. So I think this is a very good option. Unfortunately, we had a compassionate use of pirtobrutinib available up until very recently, and we're hoping it will become available pretty soon. They have opened it globally, and they have been inundated with requests, and they have basically the company has underestimated the amount of requests that we're going to have, so they have found themselves in a manufacturing and labeling sort of issue, because they don't have the capacity to manage all the requests they're having, so they had to shut it down to sort of rescale it. So we hopefully will be able to access this in the near future again. Richter's, so PD-1 blockade. So there was initial promising data of pembrolizumab with a median overall survival of 11 months and in a very small cohort with 44% responses. And they were there was a phase 1 study, and they went on to do a larger study, and then the results were really disappointing, with only 13% of response rate and a median PFS and overall survival, which was really poor. And that has been also the case for other PD-1 inhibitors. So I guess this slide is just to tell you that PD-1 inhibition on its own is unlikely to be further pursued in Richter's, because the response are not great. But there have been some recent studies about combination with PD-1 blockade and BTK inhibitors, which seems to have a reasonable outcome. If you think about an unfit patient on their 70s who cannot have anthracycline, this is a very low side effect burden, so it's potentially a good option. We'll see what comes of this. This is a study that's been published this year from a multi-center US study. As you can see, the responders on the right-hand side of the Kaplan-Meier curve have a 3-year survival, which is close to 50%, which is actually bad. So obviously small numbers as usual for this type of studies. And zanubrutinib is being combined with a PD-1 inhibitor of their own, tislelizumab, which is the BeiGene PD-1 inhibitor, and this is just a trial that has been ongoing. It's only enrolling a few patients and showing an overall response rate of 50%. Very early data presented in ASH 2019 has not been updated so far, which is a bit suspicious, because it hasn't been updated further in the subsequent ASHs. It's probably because the results are not great, but we'll see. We'll see what comes out of this trial as well. So other ways to engage T cells, so the bispecific antibodies, and I have hopefully a few minutes to tell you about this. This is a phase 2 study that was presented last year at ASH, showing a response rate of 60% and complete response of 50%, small cohort, but clearly potentially a very good option. Similarly, glofitamab, another bispecific antibody, again a small single-arm study, has been presented in Lugano this year, which shows complete response in 4 out of 5 patients. So again, very promising. Very early stages of these development. These drugs are now fully developed and well into clinical studies in DLBCL, and obviously Richter's kind of lags on, because the specific studies for Richter's are more difficult and are inherently riskier for drug companies. So that comes certainly in the second wave of studies. One bispecific antibody available for Richter's, and we hope to incorporate in one of our clinical studies from the NCRI if the results are good enough. This is another interesting study that was published in 2022 with good efficacy data with the combination of venetoclax with our EPOC for Richters. As you can see, follow-up is 9 months and the median PFS and OS has been 16 months. But the long term, it looks like there's a plateau there on the survival curve that you see on the right of about 50%, which is not bad. There's a specific schedule of venetoclax after those ramp up. They get sort of days 1 to 10 on every cycle of the EPOC to actually prevent further cytopenias, because obviously the EPOC is very myelotoxic. It is a good result. It's very interesting, but again, as I alluded before, if you think about the proportion of patients with Richters that you would be able to give EPOC is just very small. So it is a good option, perhaps, but it's not going to be a solution for the majority of patients. And there is small data again on CAR T, which has shown also good response, as would be expected for CAR T cell therapy in such setting. But the data is still very early, so we don't have much long-term data to show you on Richter specifically yet. But also watch the space, because this is something that might just come in on a second wave again for Richters. And finally, in last minute, how to treat Hodgkin Richters. A couple of big studies that I'm going to show you here. This is a large series showing that in this time span of nearly 15 years, they've only found, sorry, more than that, 25 years, they've only been able to record, and this is a large tertiary center. They haven't in Canada, they've only been able to record 32 cases of Richter, so it speaks of how rare it is. But most of them have been pre-treated, and the only factor that was associated with prolonged survival is ABVD or AVD use, with PFS of 44%, which is what you would expect, I think, for an older cohort of Hodgkin lymphoma. So it's not very different to an unrelated Hodgkin, and the message here is use ABVD when you can, because that's probably the one has most evidence about. There's another big study in which multinational, multi-center study has been able to record data from 94 patients with Hodgkin Richters, demonstrating that most of them are EBV related, again, mostly pre-treated, and confirming the findings that ABVD is associated with overall survival. Basically, the people who would not receive ABVD had a 1.63 times more probability of death and progression compared to the ABVD treated patients, and the median PFS is about 24 months, and 2-year in PFS, which is probably equates to long-term remission for Hodgkin, is about 50%. So not bad. Not bad. You can see the curves here, and the outcome of similar to what happens in the DLBCL Richters, previously untreated CLLs do a lot better than the previously treated, again, possibly related to class selection, etc. Although this is less well studied. So a small algorithm for Hodgkin, be treated as de novo Hodgkin, ABVD where possible. There's no data on BCOP here, and you would think BCOP would be rarely suitable for most of the patients who've got Hodgkin Richter, so IVD/AVD is probably the answer. You could choose a rapid versus rathal approach, depending on whether or not the disease is actually early stage or advanced stage. Doesn't have, sometimes not easy to demonstrate, because if you have lymphadenopathy and then on top of that Richter's, then it's difficult. So treat as advanced stage if any doubt. And for DLBCL, colon relationship is a good informative result, but is rarely and is not readily available. I understand that. So again, consider clinical trials. There, you go to chemotherapy would be R-CHOP or polar-R-CHOP, and I'll consider consultation with transplant patient if patient is fit and the response is good. RGCVP is consideration of the grey because of the lack of evidence, and unrelapsed novel agents or clinical studies. Final word on patient perspective. Just be mindful that these patients have been followed up for CLL, sometimes for quite a long time, and it represents a big change of paradigm for his disease, from a chronic disease to a life-threatening condition. And like I said, you've been telling the patient not to worry, this is just very stable, this is going very slowly, and then suddenly they have a Richter's that needs urgent treatment. It is difficult, and it brings people out of balance very often. There is another issue that sometimes it will involve changing consultants, CNSs, sometimes changing hospital if you have to refer the patient, and it causes a big anxiety to patients to change their kind of known set of treating clinicians and nurses. So be mindful to explore that, and to be ensuring the patient has this continuity with the other teams. And more importantly, you will treat the Richters whether you succeed or not, and you will still have the CLL as a problem that can relapse later on. And so it is also quite significant and important to tell the patients about this. And I'm gonna stop there. I'm gonna just put my take-home messages there, which is basically what I've told you throughout the presentation. Now I'll stop there. Thank you for your attention.
And we've got plenty to unpack. So could I just maybe kick off from probably elephant in the room? You just showed us the data that it's BCR independent, and yet most of your slides involved BTKI inhibitor. I mean, I do get it. Probably Stella was sort of the concept of Stella was before the data was maybe available. I mean, how would you, and obviously you encouraging us to enter, I'm being sounding very controversial now, but that's this course is about. We're going to say whatever we can say. So, part of me is thinking, it's obviously important to support NCRI and obviously ACALA, but we've got this BCR independent process. How are you going to...
I think I think the answer to that is I tend to think about cancer diseases as it has many similarities to an infectious disease. So if you think about an infectious disease where you have a resistance to an antibiotic, sometimes not all of the bacteria will be resistant to the antibiotic. And I think the same principle sort of applies to cancer and lymphoma. So yes, there is a number of or a significant number of patients that might be BCR independent, and within each individual, some of the clones might be BCR independent, and some others might be not. So that's why the principle of combination that is very attractive, because you might encounter that combining the chemotherapy with these might be able to tackle different clones of Richters in different ways, and you might find actually that one that is very resistant to R-CHOP might be very dependent on BCRI and hence respond. So I think the evidence will tell us whether or not this is reasonable or not, but I think it makes sense biologically to try different alternatives, and that's why the principle of the stellar is still attractive to me from my perspective.
Yeah, thank you. So yes, so please enter patient to Stella. Despite what I said, I think it's this is our preliminary data. So as Nick says, that basically anything can be challenged. So maybe just quickly, there are two questions in a chat. Huben asks, does every diffuse large B cell or Hodgkin in a patient with CLL background means is Richter's? Is it possible that lymphoma develops independently as second malignancy?
It is very possible. You would have to do the clonal relationship analysis and do it, but it is a clinical sort of definition. If you have a previous CLL and you have a Hodgkin arising, then you call it Richter's, and it's quite possible that it is a of a patient that has been in remission for a CLL after an allograft for nearly 12 or 13 years, and then suddenly developed a DLBCL. So you can't help but think that maybe it's just a standard de novo DLBCL, but because it's happened on the context of a CLL, you have to call it Richter's. You don't have a definitive way to prove whether or not there has been a truly de novo DLBCL. Although you might.
Do you do yourself some tests to prove it? Is it really Richter's? Do you do clonality? Do you do Notch?
Well, in this, no, I don't do. We don't do routinely do notch, but we do. Well, do the IgG mutation for the CLL, but we do. For example, for this case, that's an interesting case. But we actually did. We are able to do the chimerism from the donor cells and the Richter cells, and we've established that they are related. So it came probably. Sorry, no, they were unrelated, so it probably came from the original CLL.
Okay, thank you. Lilia, I mean, as a patient, I mean, Nick may mention couple sort of, obviously, you know, how to, you know, what's your take on it? Especially, I know you've been around with the treatment. You know, when Richter's was mentioned, was it ever mentioned to you? And you know, how do you take it?
I think yeah, I've been thinking throughout Nick's presentation, it's a really difficult topic from the patient perspective. I don't think I've had CLL for 15 years and I've had all sorts of, I don't think I've ever had a discussion about Richter's. I first came across it when I was offered participation in the Clarity trial when I relapsed. And at that time, it was ibrutinib plus venetoclax, and it was a phase 2 study. I'd heard about ibrutinib, but I knew nothing about venetoclax, so I read up on it. And the earlier studies at that time were using a higher dose. And one of what held me back, I nearly didn't take part in the study because of concerns about Richter's, because it was, I can't remember the figures, it was like 20% because they were using a very high dose. And then I think from my understanding of what I looked at, the dose in CLL in Clarity, which is I think the dose that's still used now, was reduced. So you just had to kind of trust that that would reduce the risk of Richter's. But it wasn't anything I actually took to the clinician who was offering me the study when I think back about it. It's just a very difficult thing to think about and to understand. I'm still not sure I really understand what Richter's is, to be honest. Because what it grips your stomach that this is just something that is a different ballgame, as Nick finished by saying there. And I was thinking also maybe it's something that we need to take away from this discussion and discuss more in the CLL community about what do people who go through this? I've never met anyone who's got Richter's. So I have no direct personal experience of what it feels like and we know there's huge variation in how much information people would like. And I would imagine it's a very scary thing for that person and also their families to confront. So I think it's a really good point. We need to, personally, I'll take that away and have a few discussions about how we might do more to support people who are going along that pathway, because it's very, very difficult.
Yeah, and it's quite lonely, isn't it? Because you said there's rare cases. And I think, just, if you had a patient with subset 8, which obviously has got very high Richters, do you tell them? I mean, I've got to say, I don't tell them, but I watch them very, very closely. These are not the cases I will probably ever discharge from my clinic.
I mean, the only reason to tell people is if you can help them with it. If it's just another thing to worry about, it's much more difficult to know whether you should, if it's something that you can say, you've got this and therefore we need to do that. Then it would, but yes, I'm not sure I'd want to know.
Well, exactly. I think, there will be some very rare patient who would want to know. Yeah. But I think this, you've got one big cloud over you, which is a CLL, and we discussed yesterday how, this is a chronic cancer, chronic condition. Like you said, you had to take 2 weeks to get used to the idea of CLL. I mean, and then Nick would, hypothetically, Nick, you say, in a example case patient, with this high risk. Oh, and by the way, you've got 0.5% per year of going Richters. It's another 2 months for you to get used to that idea.
But it's a difficult thing to understand what it is. So things like the treatments, I don't think it is routinely discussed that this raises your risk of Richters, whereas everybody discusses the risk of cardiac effects from ibrutinib now.
Yeah.
And it's not as frightening because everybody knows what those things are, and somebody who's had heart trouble or high blood pressure or whatever. But Richter's is just something that's, it's even hard to understand what the condition is. So all you tend to hear is that if I get this, I've got a high risk of dying and there isn't any good treatment.
Yeah.
So I think it is something we should tackle a lot more in terms of explaining, finding out what is the right level of information to explain to people, so that at least they've got something at the back of their minds, maybe, that if they do get it following treatment, it's not something they've never heard of before.
Yeah, as Lydia mentioned about the chemoimmunotherapy, there is a first question, Nick, on the chat from Tom. So it's a bit of a probably kind of kitchen and egg question, really. Does the increased risk of Richter's post-chemotherapy causative relationship to chemoimmunotherapy, or basically there were more high-risk patients? And also, if I could kind of put it together with this, because to something which Helen mentioned about Notch and about doing NGS routinely, and should we maybe sort of plan different treatment for those patients?
Well, a few ways to answer that question. I think there has been several large cohorts of treatment-naive CLL patients that have been followed up, and even if they have high-risk features, they don't seem to have a high risk of Richter's compared to the non-high risk, or too high, or too different risk of Richter's, I think. So, I think there is an effective treatment, but it's fair to say that that treatment will have a deeper effect if you're a high-risk disease, because you have already a set of mutations that will make you more susceptible to gain sort of secondary, that will probably make you more susceptible to Richter. So it's kind of a snowball that keeps kind of getting bigger as you go along in treatment, even you're high risk from the start. And then what to do with the Notch1 then? I think the Notch1 are high-risk CLL by nature, although that's not recognized yet as a kind of sort of fully independent prognostic, because it's so sometimes co-segregated quite a lot with TP53 and other karyotypic alterations. So it's difficult to, I haven't seen yet data that teases out specifically that the Notch1 is independent, truly independent. In any way, it is a high by all definitions. I assume you're asking if the Richters had if a Notch1 CLL develops a Richters and they get to remission, would I offer transplant? Where if they're young and fit, probably would consider it if I have that data with me at the time. And if it was a high-risk CLL anyway, this is a sort of group of patients that I do consider quite intensively for transplant when you start exhausting different lines of therapy. But I think the evidence is I think the outcome of the patients that have been transplanted is reasonably good, and I'm a great believer in graft versus leukemia effect in CLL. But again, is not an absolute. And as I've spoken earlier on in my case example, that you can have Richters even 10 or 50 years after allograft. So it's not like it's going to be a definitive solution, but it may reduce your risk quite significantly.
Yeah. Adrian, what's your thoughts about this?
Sorry, Renata, apologies. I thought I was trying to answer another question.
Yeah, sorry, no, because you just put a very good answer to the Notch thing. So I thought it would be good to share with the audience what you've just put in.
About Notch or subset?
Yeah. So, sorry, the one. You just replied to us about the Notch question. About the biomarker.
The biomarker thing, I was more about how do you use the information? I in a sort of more general sense of that we know much more about how to do the tests than we do about how to interpret the results and what to do with it. So I personally do have conversations with patients about all the results that come back from their NGS panel, but then usually with a fairly rubbish. What I always feel that I'm never really able to give them a conclusive answer about what to do with it. in as much as if you look at most of the biomarkers tell you about poor prognosis, also you pick out poor things, but they don't tell you which is the right treatment. I think, beyond saying P53 deletions or dysregulation, I would give continuous treatment because that seems to be what we're going for. Patients who've got really good prognosis disease, maybe my prejudice is that they get Veno because the data look very good. Beyond that, I think it's extremely difficult. I think the question about transplants, I wouldn't transplant anybody unless they have failed 2 lines of targeted treatment, generally. And I think that I just don't think we have the data to say that the risk is justified for doing that. And then the other question that sometimes comes up, but it's really related to where you are, is CAR T therapy as well. When do you use cellular therapy, or how can you change the treatment pathway for patients with high risk disease? I don't think we know the answer to that, in the sense that all of these, many of what we get, the information we get, there is not a way that you can necessarily give certainly not an evidence-based approach for it. And so I think some of the things comes down to personal. When I look at it, I say I give them treatment because of my gut feeling or prejudice, rather than whether there's actually, rather than saying I can prove this is the right thing to do.
So you mentioned CAR T. So is CAR T available at the moment for Richter's? Had I had a patient with Richter's? And how fit would they be? Would they have to be?
Not for Richter's. I mean, I think that it probably doesn't work very well in Richter's. That would be my worry, in the sense that it's like CAR T doesn't work for, I think, in very advanced disease. Transplantation, we transplant patients for Richter's, but I mean, I think that I can't remember the last time we did, because it's relatively rare and most of the patients aren't fit enough to get to it. I mean, it's there as the standard indication in the transplant guidelines, but hardly anybody gets there.
Yeah, I was surprised that there is a data you showed for the autologous transplant. I presume that's even less so, isn't it? I mean, the allogeneic makes more sense, but actually putting patient through auto, and it's just, yeah.
I think it adds toxicity. I'm not sure that adds anything to longevity.
Yeah. Helen, anything to add to what we just discussed, as you were originator of that biomarker question?
We're just finding this quite a bit. I think because we have NGS up front, so anytime we're sort of diagnosing, going towards treatment now, we obviously are doing the NGS and finding more Notch 1 young, fit patients that, have got decades of life ahead of them. And so we've gone for the sort of second line in MDT discussions in terms of planning for transplant. And I think that's probably along the lines of what Adrian was just saying, but there's not the data out there really to support, to know, and it's sort of putting all the data together to sort of come up with a sensible route forward for young patients. I think that where, they've got these adverse prognostic features.
Yeah. So Nick, in summary, I mean, we've got 2 minutes to wrap up before we go for a quick break. Take home messages from your, so what would you, people seeing the Richter's patient next week?
I think the take-home messages the main messages hasn't changed very much in the last 10 years, but watch the space, because I think is going to change with the advent of the bispecific antibodies. I think they are going to make a difference, particularly in Richter's. So for the moment, I think comes with your patient's well diagnosis. The treatment, obviously, polatuzumab R-CHP is available, and it is anyone's guess if it will be better or not, but it's an option, and I would certainly use it with care in the older patients. And thankfully, and finally, just be mindful when you diagnose a Richter's to communicate well with your patients and go through all the anxieties that come along the new diagnosis and the potential change of hospitals, treating team, etc. Because I think that's very important to support the patient throughout the line.
Yeah, I think this is probably where CLL support maybe could look something sort of just to join the dots, because it's stressful enough to have the diagnosis, but changing the team you got used to and trust as doctors, and then you need to build up a new relationship. I think there's something like that. It's at the background to support them would be really useful. Okay, on that note, let's have a 5 minutes break.